Hi everybody and welcome. My name's Irene Mooney. I'm the CEO of MYVISTA, an aged care provider of residential aged care, home care and retirement living. And I'm very pleased to be able to be presenting our Advanced Care Planning series to you. This is the last one in our series, and today I'm joined by Michelle Harris-Alsop. And Michelle has got a long career working as a nurse and in aged care. But Michelle is a dementia and palliative care nurse consultant and the owner of Care Partnerships Australia. She specialises in helping people with dementia, palliative care, education, and is a well-known person at MYVISTA helping us with our staff training, but also our customers and our residents in having some of those difficult conversations around advanced care planning. So, welcome, Michelle. Shall we kick off our discussion today?
Thank you.
And I thought we'd start by you just giving us a bit of an idea about, from your perspective, what the difference between an advanced care plan and an advanced health directive are.
Well, an advanced care plan is that prerequisite. It's the discussion, informal discussion, and maybe note-taking on an advanced care plan document about your rights, your preferences, your wants, your needs to maximise your quality of life from when things start to change in your life. And that might be a cognitive change, a physical change, or both. It's about you having control of somebody being your spokesperson. So you're already voicing to your family, your siblings, what you want. So when you've done that and you feel comfortable with that discussion, then you can formalise it into an advanced health directive, which is the legal, document that our health professionals will use in medical practice, aged care around Australia, although it does differ from state to state.
And so if you have someone coming into residential aged care, is that a good time to start a conversation around an advanced health directive?
I would say it is probably best to have those conversations before. As soon as you're ringing My Aged Care or the NDIS and you're looking for some support at home, none of us know how long life is, but having control and having those conversations before seeking residential aged care is my goal, so that they've got some formal healthcare directive when they arrive. Because often there's a lot of grief when someone's moving into residential aged care, and people living with ambiguous loss, wondering about what's going to happen to their pets, their family, their home, their possessions, and all that shrinking down, and then having to make decisions. It almost takes away some of the excitement of moving into a different place with new people that are going to support you. So personally, I've often said to my family, let's talk about this now. But I actually respect people's choices, and I understand that having those conversations is not easy. And that is often where they rely on aged care providers like yourself to navigate that for them. But that then mixed with the grief of loss of home, loss of independence is, to me, a lot.
There's a lot going on,
And people are staying at home longer now, which is fantastic. But then when they come to residential care, they're more, sick or frailer, deteriorating in mobility, deteriorating independence. So we need to be mindful of that. How much do we want to burden or, we need to support the person-centeredness of what is going on.
For MYVISTA, perhaps starting that conversation around an advanced health directive or advanced care planning when people come to us for support at home is an ideal time.
Absolutely. And I think it gives that person a chance to be involved more, because I believe in listening to the person that's changing. None of us can escape old age. It's part of life. It's a privilege, but also it comes with lots of different concerns. And I think having control from the beginning, of having a sense of being in control of this is what my life will look like, maybe talking about living with risk but minimizing harm. What does that look like?
Yep.
I think sometimes, with respect, families can often forget that the person they're talking about needs to be included, even when they've got a cognitive diagnosis of dementia. I still don't talk about things without them.
Yep.
I don't know what you're thinking right now. You don't know what I'm thinking. Why do we assume that someone with global aphasia or a stroke or dementia isn't actually thinking about, this is what I want? They may have difficulty expressing it, but they might be able to write it down.
Yes, so remembering there's a human being all the time.
Absolutely.
Yeah. Thank you. Michelle, how do I or the staff start a conversation about advanced care plan with their mother who does not want to talk about planning for the end of their life?
I think it can be done in an informal way. I think sometimes people, in an era of fearful of death, a death-denying society, which we are in Australia, when you actually mention, they actually think, oh, you're going to hurry me, or, you're going to hurry me off this mortal plane. I think having the informal conversation, Mum, what do you want us to do when something happens and you go to hospital and the doctors tell us there's nothing that can be done? What should we do? And if they say, I don't want to talk about it, maybe seek some professional support like you provide at MYVISTA, or external relatives. Sometimes the daughter, the mother may not want to talk to the daughter because she wants to protect her daughter, but she might enjoy the daughter's friend, or she might want to talk to her own friend, and that might be over a cup of tea, and might have no paperwork in front of you, but you're just talking about it. Often, in experience, it isn't the family that the person wants to speak to, because the family are the person who's aging is protecting, or the husband is protecting the wife, or the wife is protecting the husband. So I think it's important not to feel a failure if you can't, but think outside the box and think, well, who else would she talk to?
Yes, I think we do sometimes forget as children with our parents that they've had a full life. And when we haven't been there, they've had associations and friendships and conversations with people that we're not aware of, and those people can help.
And I think that is so important, Irene, that we don't forget the person. Yes, there may be a list of reasons why we need to have this conversation. There may be physical changes, deterioration in front of our eyes, but you still can't forget that this is a human being, and they've got every right to be involved in decisions that are being made about their life.
Yes, and I think just as we're moving into the New Aged Care Act, that has actually now put that in legislation, that everything must come back to the individual to make a decision, or at least be involved and included in that decision-making, is a really good example here when we're talking about advanced care planning.
Absolutely, and I think that's exciting for me. I'm really pleased that that's happening.
I think it's a positive step forward for individuals. Michelle, if we use a scenario where we talk about my dad has early onset dementia and has diminished capacity to make decisions, and I'm his guardian, how do I get support to write his advanced care plan?
A good example would be a medical person, or maybe palliative care WA. They offer a free service where they'll do by appointment a consultation with you to help you get those questions out. Also, sometimes I will say to the family, if I was the person facilitating that, if your dad could look down now on this situation 5 years ago, what would he have told you then? And that gives an actual, I guess, takes the emotion out of it, but almost makes it more thought-provoking about, is this my thought or is this what I think my dad would want? I don't think that we should be fixated that when a plan is done, an advanced care plan is done, that it can't change. You know, I've known people who have had a diagnosis of early dementia, but through re-enablement, through support at home, through art therapy, music therapy, cognitive stimulation therapy, they've stabilised. Yes, they've got that backup brain person that's coming in to make sure that they're having nutrition and that they're moving and that they're socially engaged, but they've not deteriorated. So I think that's important to think about that, you know,
Yes.
that the Advanced Care Plan is a guide to the Advanced Health Directive, but it can change.
And also, Michelle, is it important in that scenario that often there could be a partner, a long-term partner, spouse, and then something could happen to them, and then others are having to try and guess
Yeah.
if it hasn't already been written down?
And that is very, very difficult, Irene, and I see it a lot. You know, often the carer is the spouse or partner, and they become ill and frail and have an unplanned hospital admission and then decline and leave this earth. And that then puts the onus on that family, and it can be overwhelming because then you've got that decision, do I give up work to be the person that lives with my father? No, financially I can't give up work. So therefore there's all this stress. When realistically, if we think about, you know, having some sort of control over having things planned. So when people become frailer and are in the terminal stages of life, we don't have to think about that then. We can actually be there and provide the comfort and get supported through good palliative care staff to be able to not worry about all that stuff.
And just be present.
And just be present and be the daughter.
Yeah.
You know? And
Yeah,
I think
very
I see it
important.
so often where, especially in siblings, where there's that rivalry of one sibling thinks one thing and the other one thinks another. And you're, as a nurse consultant, in between trying to support them both, realising that they're both grieving for the loss of their mother or father. But at the end of the day, someone's got to make the decision, and this is a very difficult time to make it.
And on that, is there something that you think staff could do or those that support the family when there is a bit of rivalry or disagreement? And that could be for lots of things. It could be distance, it could be family dynamics, it could just be how people view their own lives and lifestyles. Any tips or ways that staff or those working with the individual around advanced care planning can help?
Definitely. So first of all, as a nurse consultant, I would say to the staff involved, don't tell, ask them what they understand is happening right now. Because as a clinician, I know, I can see what's happening. This person's deteriorating in front of my eyes. But the other family members may not know that, or one family member may and the other may not. So when you start that curiosity, conversation, if that fails, and it can fail, where we get, well, I don't agree with her or him, that is when I would use the counselling service at Dementia Australia, if it's to do with dementia. They do fabulous services there at Dementia Australia. Or I might use Advocare or Relationships Australia. Yeah. If I'm in a hospital situation, I might rely on the social worker. But I think it's really important that it's done very carefully, because we're talking about a human being here. And we can't lose sight of the fact that when someone you love is leaving, you're in a lot of grief because you're losing part of yourself. So you have to be mindful of that we might not be able to fix it right the first time. We might have a few sessions, but do we have that time? That's the other part of leading on to why we should start this earlier.
So am I right in what you're saying there as well is for staff and others to understand that sometimes those differences of opinion, are those individuals expressing their grief differently?
Absolutely. And, we've got to remember that the way we react to that is we're in control of that. We're not in control of what that person is going to be like in that moment, but we are in control over how we manage our own emotion.
Yep.
And I think that's really important, and that as professionals we respect that.
Michelle, you've been doing this a lot, and I know you've supported a lot of individuals and families.
Mm-hmm.
What does a good death look like to you?
Mm-hmm.
And how could MYVISTA help make that possible for individuals that are in our care?
A good death for me, and I've witnessed many, and it's a privilege, every death is different, but a good death for me is where the symptoms, the physical symptoms of breathing difficulties, maybe continence issues, skin issues, pain issues, that those symptoms are managed and reduced. The distress for the person in the bed is reduced, and that they're comfortable. I also think anxiety, emotional distress, spiritual distress, that when we see those symptoms, they're managed too. So I think having a good palliative care team at the bedside, working in partnership with the carers and the people involved, the allied health, the family together as one unit, working together, allowing the family time to ask questions, but also involving them as much as they want to be. For some families, they don't want to be, and I respect that too. But I think having staff clinically trained to know distress, physical, psychosocial, spiritual distress, and working closely with your medical team to make sure that that person's not suffering and just goes to sleep is a beautiful death.
So having an advanced care plan and the goals of care in that the individual has expressed, that sort of gives the staff something to keep going back to help them with what they're trying to achieve, and as a reminder of what that individual wanted to achieve.
Absolutely. And I think, having your staff trained with the SAS, the Symptom Assessment Scale, we've got it in different languages, haven't we? Which is fabulous. And I think having staff who can read a room and notice if a family member is in distress and how they can support them, and if they don't have the skills, escalating that and asking for help. I think that's important, and knowing that the person, that we're all there for the same reason, aren't we?
Yep.
Not forgetting that anybody else is important. It's the most important thing is the person that's leaving. We labour to be born to this world often, and we labour to leave. That's how I see it. I almost say, I was with a family the other day, and their mum died, and then their great-grandchild was born the next day, and I was saying, Auntie's just passed the baton in the sky, that kind of thing. But I think if we think about this, it is the circle of life, and we needn't make it as stressful as it can be. We need to be mindful of everybody's needs and preferences are different, and we as a clinical team need to be able to read when that goal of care is not working and that person is struggling.
So, Michelle, in your experience, what would be some effective ways to normalise discussion about death and dying in everyday residential aged care settings?
Asking questions. Tell me what you understand. So, if I give you an example, we monitor people's weight. We monitor people's skin. We look at pain and movement. As an outside person, for somebody who may have no idea that unplanned weight loss can indicate deterioration, and sometimes adonia, where you don't actually have the ability to relax, to enjoy pleasant things anymore, can be a normal part of dementia for some people, not for everybody. I think it's important that by asking the family or the next of kin or the friends, tell me what you understand is happening, it actually then allows that context for, well, can I tell you what I'm seeing? And can we look at the last 6 months or the last 3 months, or since the last hospital admission. But I think having the openness, the dialogue, it's safely in a nice place, not in the middle of a corridor. I'm talking about having a place where it's private.
So staff having a skill set that still allows them to meet their required legal requirements,
Yeah.
but being able to present it in a way that is in partnership and in consideration of all the people that are in the room.
Absolutely, including the person, especially them. And if they don't want to be there, respecting that too. I think that's important, that for some relatives, I might meet them first before we meet the person that's deteriorating, because they are frightened of asking those questions, or they want to ask questions outside the room. And I think giving them that safe space to do that is fine, but realising that we can't formalise that advanced care plan until they're with us.
Yeah.
And remembering, if English is a second language, that we need an interpreter, and that may not necessarily be the family member.
Yes.
And being curious about that, is this the right person to be interpreting? I'm always mindful about, making sure that their words are being heard if English is not their primary language.
And just before we wrap up, is there anything that you'd like to say or put forward that you think would be beneficial to this conversation?
Having been working with you and many other providers in WA for a long time, I feel it's important to recognise that new graduate nurses today need coaching and support by people like yourself or others in this area who have got that experience, because it's important for them to grow the confidence and starting these conversations. You don't really learn this in uni or even in the time that you're training. I learnt that through my time in Manchester as a staff nurse, watching the sister talk, or the doctor, the geriatrician, talk to the family. I think that's important, that we've got to have good coaching and good experienced people giving this information or sharing this information with families. And carers as well, feeling confident to noticing. I think that is, for me, the last thing that I would say, that we've got an ageing population and yet we've got a reduced professional workforce available. So how do we build capacity and confidence in the staff, and at the same time the trust of the families? We need to allow people to learn and maybe not speak but just witness it.
Yeah.
Hopefully this podcast as well. I think that's a great way of what you've done here. Maybe that can be helpful.
So thank you, Michelle, and thank you for your insights and for joining us today. We really appreciate it. And some takeaways from Michelle, I believe, are remembering the individual, person-centred care, listening, asking questions, be curious, because curiosity actually opens up for others to say things or be included, where if you just ask questions at them, you might not get the answers or they might shut down. So that's the end of today's series. So thank you very much for joining us.
Thank you, Irene. Nice to be here.